Alrighty, so today we're going to do a mini lesson on diabetes. I am ChicagoDLSinc. I do one-on-one tutoring for the Naplex and the MPJE. If you've taken the Naplex before and would like for me to review your score report and give you feedback, feel free to send me a direct message. If you are taking it for the first time and have taken an assessment or have questions, also send me a direct message. Shout out to Suspicious Bunch and Pharma Turtles for arranging this. If you have questions or concerns, please save them till the end. I'm happy to answer all of them. And we will do a mini lesson and then do 4 practice problems. I use RxPrep and Past Naplex now to put these together. Either one of them on their own are great resources. Whichever one you choose for your prep, make sure you do as much as you can, and you should get the result that you are looking for. All right, let's get started. So, we'll start out with the complications of diabetes. I was taught by a mentor that anywhere there's a blood vessel, you can see a manifestation of diabetes. And because we have a blood vessel, either small or large, all over our body, you can see complications or disease manifestations. So, microvascular are going to be in the small blood vessels. So, we have retinopathy. You can notice diabetic macular edema. In the kidneys, we have nephropathy. There can be renal failure, neuropathy in the nerves. So there can be diabetic autonomic neuropathy and peripheral neuropathy in the hands and the feet. Now, the DAN is going to be the autonomic nerves that manage body functions, so BP, heart rate, bowel motility. And in the bowel, you can have gastroparesis, which is decreased bowel motility, causing nausea, vomiting, abdominal distension or pain, and bloating. Macrovascular complications are going to be CVA, which is cerebrovascular accident, aka stroke. And then you can have atherosclerosis of arteries and coronary artery disease affecting the circulation of the heart, and peripheral vascular disease or peripheral arterial disease. So, testing criteria for prediabetes or diabetes in asymptomatic adults. Testing should begin at the age of 45 years, younger if they are overweight and have additional risk factors. I'm not a big fan of BMI, however, for the testing purposes, you need to know BMI over 25 kgs or over, or in Asian Americans, 23 kilograms or greater. Physical inactivity, first degree relative with diabetes, high risk ethnicity for diabetes, women who have delivered a baby greater than 9 pounds or who have had gestational diabetes, hypertension, HDL below 35 or triglyceride greater than 250, and history of cerebrovascular disease. Now, diabetes is quite vast, so I'll be doing another session possibly next week, and we will do more background and we will do more medications, and there may even be a diabetes 3 presentation as well. Gestational diabetes, this is diabetes while pregnant, and we want to diagnose and treat to reduce the risk of fetal macrosomia, shoulder dystocia, and preeclampsia. Now, preeclampsia is going to be hypertension and a positive urine screen for protein. Shoulder dystocia is going to be a birth complication, and then fetal macrosomia is going to be a large fetus. So there's a 2-step diagnosis and a 1-step diagnosis. For the criteria on this slide is going to be the 2-step diagnosis. You have screening for gestational diabetes. You do a 50-gram oral glucose. Fasting is not required. In the 24th to 28th week of pregnancy, glucose will be measured 1 hour later. If the value is 140 mg per deciliter or greater, then you do the full glucose tolerance test, and that's going to be the 100-gram load test after overnight fast. And then we need to see, is the fasting greater than 95? At 1 hour, is it greater than 180? 2 hours greater than 155, and 3 hours greater than 140. If you have two of those criteria, then you can proceed with a diagnosis of gestational diabetes. The one-step diagnostic method, you do 75-gram oral glucose tolerance test at 24 to 28 weeks after an overnight fast of at least 8 hours. We can diagnose gestational diabetes if any of the plasma glucose values exceed 92 for fasting, 180 at 1 hour, and 153 at 2 hours. Excuse me. Treatment of gestational diabetes are going to be diet and exercise. Insulin is the gold standard. NPH and regular insulin have the most evidence of safety. Metformin or glyburide can be used for mild cases. Now, some of you may have read we avoid metformin in pregnancy. We try our best to. Can anyone tell me why? In the chat, please type what effects metformin can have on the fetus. If you don't know, that is okay. Next, we have goals of therapy. Overall, the goal needs to be, the A1C needs to be below 7%. Okay? The AACE, the American Association of Clinical Endocrinologists, they prefer 6.5% or lower. The ADA recommends 7% or lower, or below 7%. Going back to metformin, talking about why we avoid metformin. It is excreted into human milk, and it can have an effect on the kidneys. Now, it is not assigned currently, and as we talked about in the previous categories about pregnancy, A, B, C, D, and X are being phased out. However, you want to make sure that this would be considered C, that the benefits outweigh the risks. Now, poorly controlled diabetes in pregnancy, and I'll add that to the presentation, increases the maternal risk for DKA, preeclampsia, spontaneous abortions, preterm delivery, stillbirth, and delivery complications. Going back to the goals of therapy, we have a less stringent A1C goal, such as lower than 8%, may be appropriate for some patients. For example, frail, elderly, or those with a history of severe hypoglycemia. Now, informally, I've heard from internal medicine docs that below 200 for a random blood glucose is okay, and then you work your way down. Remember, there's so many factors that go into diabetes, whether it's diet, exercise, lifestyle, and you have to be willing to work with the patient, uh, and not just with diabetes, but in any chronic diseases. So, BP less than 130 over 80. The American Heart Association or the American College of Cardiology, they say below 140 over 90. And then the JNC says, which is the Joint National Committee, below 130 over 80. Microalbumin in the urine, you want less than 30 mgs every 24 hours. EAG, is estimated average glucose. This is going to be over the past 3 months. The formula is going to be 28.7 times the A1C minus 46.7. On the right, I have a table that has the A1Cs 5 through 10 and the estimated average glucose. Excuse me, I had a student who told me that they had memorized this table and they would guesstimate based on it. However, there is a formula 28.7 times A1C minus 46.7. All right, very good. Nikki has a question. How or when do we use the different guidelines for blood pressure and A1C? Will the exam let us know which guideline, or is there a universal A1C and BP? So that is a great question. 7 should be what you use for the A1C, for the percentage. I cannot give you a definitive answer for the BP because there is the both values are used 140 over 90 and 130 over 80. So unfortunately, I don't have a definitive answer for the blood pressure. I would say maybe remember both sets of numbers and evaluate the question based on that. So treatment guidelines, ACE inhibitors or ARB, especially if microalbuminuria is present and or if eGFR is below 60 mil per minute. Aspirin, we do baby aspirin, but 75 to 162 mgs shows the best positive results. It's recommended for secondary prevention in diabetics with history of previous MI or stroke, and it is considered for primary prevention in diabetics at high risk or diabetics that are 50 years of age with one risk factor, such as smoking, dyslipidemia, hypertension, family history, and albuminuria. Now, if you weren't sure before, know that albuminuria means that the kidneys are not filtering protein effectively, and so you definitely have to take measures to protect the kidneys. These guidelines are not recommended for low risk diabetics, and the age and the percentages are listed. A P2Y12 receptor antagonist, such as ticagrelor or clopidogrel, plus aspirin should be used for at least 1 year after acute coronary syndromes. Can anyone in the chat tell me a brand name for ticagrelor, please? In the chat, ticagrelor. All right, well, I give everyone a chance to respond. Let's continue. Treatment guidelines. We're going to have statins. These are the ADA guidelines. And if they're diabetic below 40 years of age, only if they have risk factors. 40 to 75 years, you're going to do moderate intensity. If they have risk factors, you'll do an high intensity statin. If they're above 75 years of age with no risk factors, similar guidelines, moderate intensity. And if they have risk factors, then moderate or high intensity statin. Risk factors are going to be LDL greater, less, sorry, LDL 100, smoker, albuminuria, or family history of premature arteriosclerotic CVD. So, if you answered Berlinta in the chat, that is correct. Very good. Know that the Naplex is very high yield for brands and generics. Excuse me. You may get all brands, you may get all generics, or they may mix and match. In the resource section, Suspicious Bunch has posted a link for the top 200 and top 300. I always recommend doing the top 300, and you don't have to memorize them all in one go. Try to do 5, 10, 20 every day along your prep. So the ACC or AHA, once again, the Cardiology or Heart Association guidelines. This is based on the LDL levels. If they're 70 to 189, they're going to be moderate intensity. If there are multiple risk factors, you're going to want to do high intensity statin. At the bottom, I wrote review low, moderate, and high intensity statins. This is also very high yield. Sometimes you'll get a question that asks you to switch, or is the patient on the appropriate intensity statin? And just a reminder, ASCVD stands for arteriosclerotic cardiovascular disease. So checklist after diagnosis. You're going to want to have an eye exam annually to check for retinopathy. A foot exam each visit. We want to check pulses and for signs of infection. Diabetics need to be taught to trim toenails straight across and check their feet every day. Now, with peripheral neuropathy, they'll lose feeling and they'll lose sensation. So it may be hot outside and they walk outside barefoot and burn their feet. They may go outside and step on something and not know because they've lost feeling, and that can lead to an infection. That's another guideline is you never go anywhere barefoot for diabetics. For treatment of diabetic foot infections, if it's mild and superficial, usually causative agent is strep and methicillin sensitive staph. We do Keflex or dicloxacillin. For MRSA, we'll do Doxy or Bactrim. For deeper infections, we can add coverage for gram-negative bacilli and anaerobes, especially if it's polymicrobial. And for infections with systemic toxicity, we may need to add IV empiric antibiotics. All right. Next, we have immunizations for diabetics. All diabetics that are greater than 6 months old, uh, you get the annual flu vaccine. Pneumococcal as well to all diabetics that are greater than 2 years old. Pneumovax 23, they get one dose. And if they reach age 65 and not have and have not received Prevnar 13, they get one dose. And then we want to repeat the PPSV 23 one more time after age 65. We want to make sure that there's a 1 year gap between PCV 13, and we want to make sure there's 5 years or more gap between the last PPSV 23 dose. Can anyone tell me in the chat what PCV stands for? PCV in the chat. For Hep B, we have two 3-dose series vaccinations for diabetics that are 19 to 59 years old. For older patients, it's based upon risk of acquiring Hep B and the likelihood of an adequate immune response to the vaccination. All right, getting some answers for PCV. Very good. So, type 1 diabetes, mellitus or mellitus. 5 to 10% of patients. Age is usually less than 30 years of age. There is no pancreatic function. Pathogenesis, the islet cells have been destroyed by antibodies, and it is an autoimmune process. There is often a history of ketoacidosis, aka DKA. And clinical presentation, the symptoms will progress rapidly. Polyuria, polydipsia, fatigue, weight loss, and ketoacidosis. Treatment here is going to be insulin, diet, and exercise, with insulin being the mainstay. For PCV, if you answered pneumococcal conjugate vaccine, that is correct. Great job. So, type 2 diabetes is about 90% of diabetics. Usually we see greater than 40 years. Pancreatic function is working. Insulin is present in low, normal, or high amounts. Now, what do I mean by that? Your body can have reduced sensitivity to the insulin that your own body is producing. So it can be that type 2 can be, you can have low insulin, your body's not producing enough to control blood sugars. It can have normal or high, your body is just not sensitive to that. So, oh, and that's the pathogenesis. There can be a defect in the secretion or the amount of secretion, and there can be tissue resistance. Also, there can be increased hepatic glucose output. Ketoacidosis is rare. There's actually a condition called HHS, and that is what you see mostly in type 2 diabetes. All right, and that's going to be, I'm going to type it into the chat, hyperosmolar, hyperglycemic syndrome or state. Excuse me. Clinical presentation, there may be polyuria, polydipsia, but type 2 is usually diagnosed on routine screening. So someone has a yearly physical, their fasting or random is high, A1C is sent out, and you get your diagnosis and your confirmation. Patients usually have weight gain as opposed to weight loss, lack of energy, blurred vision, and candidal infection. Type 2 DM treatment is going to be diet, exercise, and oral agents. So we have biguanides, sulfonylureas, TZDs. By the way, if you use the full form for TZDs as your Wi-Fi password, I will use my data way too long. DDP4 inhibitors, SGLT2s, meglinotides, and alpha glucosidase inhibitors. Sub-Q non-insulin agents are GLP-1 receptor agonists. These are the ones that are all over social media, and people are using them not just for diabetes, but their side effect of weight loss. Last but not least, insulin when it is not controlled with oral agents. So last slide is going to be cassia cinnamon or cinnamomum aromaticum. Excuse my pronunciation. So cinnamon, as you know, it's used in desserts, it's used in coffee drinks, and used as seasoning. It may improve insulin sensitivity and decrease glucose in patients with type 2 diabetes. Taking it is safe likely when used up to 4 months. It contains coumarin that has been linked to liver toxicity when taken in high doses. Advise patients with liver disease to avoid cassia cinnamon in large amounts. You've probably seen cinnamon teas being marketed and cinnamon supplements, so please be careful about your liver. And also, if your blood glucose is 300 and you take a gallon, you take not a gallon, but if you eat like a bowl of cinnamon, it'll probably just irritate your throat and not lower your blood sugar. So now we have arrived at the 4 practice questions. If you're new, I will read the question, and at the end of me reading the question, Please be so kind as to put your answers into the chat. If you're not sure, put a question mark. And if you are guessing, that's fine as well. Here is the space for you to get it wrong and learn from it. So when you take the Naplex, you get it right. So let's start with practice question 1. Which of the following medications for diabetes would carry the least risk of hypoglycemia? Choice A, glucophage. Choice B, glucotrol. Choice C, Lantus. And choice D, Humalog. Once you have put your answer in, please let me know what the generic is for glucotrol. Choice B. What is the generic for choice B? Okay, so the correct answer is choice A, glucophage, and that is metformin. So if you chose A, that is correct. Metformin is the least likely to cause hypoglycemia as it doesn't stimulate insulin release. Choice B, glucotrol, which is glipizide. It is a sulfonylurea, and that directly stimulates beta cells to release insulin. So all three of those, B, C, D, are carry a risk for hypoglycemia. So that is practice question 1. Good job. All right, practice question 2. A 66-year-old diabetes patient has been recently diagnosed with congestive heart failure. Which diabetes medication would be least appropriate given this new diagnosis? Okay, so the correct answer here is going to be B, pioglitazone. This class of drugs, TZDs, should be avoided because they can cause fluid retention and can exacerbate congestive heart failure. Good job if you chose B. All right. Let's talk about practice question 3. Which of the following scenarios represents appropriate storage of insulin product, assuming the stored products prior to opening were before the expiration date? Select all that apply. Choice A, 56-year-old male with hemoglobin A1C of 7.5, kept his Lantus Solostar product refrigerated unopened until 60 days ago when he began using the product and storing at room temperature. He continues to use today. B, a 43-year-old female with hemoglobin A1C of 6.9, kept her Toujeo Solostar refrigerated unopened until 45 days ago when she began using the product and storing at room temperature. She is continuing to use it today. Choice C, a 24-year-old female with hemoglobin A1C of 7.2 picked up her Afrezza product 3 days ago. Excuse me, at the pharmacy and has kept at room temperature since beginning to use the day she picked up the prescription. Choice D, a 65-year-old male has stored his Basaglar QuickPen refrigerated unopened until 40 days ago when he opened and kept at room temperature. He is still using the product today. A 72-year-old female has stored her Tresiba Flex Touch in the freezer unopened until 15 days ago when he opened and began using. She is still using the product today. Remember, this is a select all that apply. One can be correct, all can be correct, and anything in between. While you choose, this is an area 5 question. Compound, dispense, administered drugs, or managed delivery systems. We'll give everyone a minute a chance to respond. Okay, so sorry, my allergies are really acting up. Choice B and choice C are correct. And let's talk about why. B is correct. Toujeo Solo Star gives you 56 days to use the pen after opening and storing at room temperature. Choice C is also correct. Afrezza is an inhaled insulin product. It can be stored unopened for up to the expiration date in the foil package, or if they are blister cards and strips, up to 1 month, or up to 10 days once opened and stored at room temperature. Now, no one chose A, which is good. A is incorrect because room temperature is up to 28 days for Lantus Solo Star. D is similar. 28 days is the guideline for that formulation of insulin glargine. Choice E is incorrect as insulin should never be frozen. All right. So, good job if you chose B and C. Let's go to practice question 4. You have been tasked with providing a pharmacotherapy presentation for an internal medicine residency grand rounds on diabetes mellitus management. In preparation for the lecture, you are gathering the most up-to-date information, which you believe would be practical for the audience. Which of the following statements are true and would be appropriate to include in the presentation? Select all that apply. Choice A, Afrezza therapy is contraindicated in patients with uncontrolled hypertension. Choice B, all FDA-approved GLP-1 agonists for diabetes management are injectables. Choice C, Invokana can cause genital yeast infections. Choice D, Actose is recommended primarily for diabetes with heart failure. Choice E, concomitant use of Victoza and Januvia may lead to increased risk of pancreatitis. Choice F, certain SGLT2 inhibitors have proven benefits in heart failure, CKD, and CVD. In choice G, the rapid-acting insulins include Lantus, Levemir, and Tresiba. This is going to be area 2, identifying drug characteristics. All right. Anyone else want to put their answer in? Okay. So the correct answers are going to be C, E, and F. And let's talk about why. No one chose G, which is good because these are all the long-acting or basal insulins. The rapid-acting insulins that are used for bolus or mealtime coverage are Novolog, Humalog, and Apidra. So good job. Choice F is true because this class of drugs have proven benefits and they reduce heart failure as well as progression of chronic kidney disease. In addition, empagliflozin and canagliflozin have specifically received FDA approval as agents that reduce cardiovascular risk in patients with established cardiovascular disease. So, F is correct. Good job. Choice E is true. GLP-1 agonists and DPP-4 inhibitors both carry the risk of pancreatitis as an adverse reaction and therefore should not be used together. Choice D is false. I'm glad no one chose that. There's a box warning on this drug, which can cause fluid retention and edema, which exacerbate heart failure. Next, we have choice C. This is true. SGLT2 inhibitors can lead to an increased risk of bacterial and yeast infections. Answer choice B is false. Semaglutide comes as both an injectable, which is Ozempic, and an oral tablet, which is Ribelsis. And of course, answer choice A is false. Because it's an inhaled insulin, it is contraindicated in severe pulmonary diseases such as asthma and COPD. Okay, the end for today. If you have any questions or concerns, feel free to reach out. Please fill out the survey so we can improve if you have not done already.